Hello everybody, today we have a neurology question, step 2. So we have a 34-year-old woman that's complaining of a headache. So when you see a question about a headache, you want to know, is this a primary headache or this is a secondary headache? And the way you can know that through the history and the examination. So let's read more about it. She describes the headache as being worse on awakening and on bending over. Now immediately you should think that this is something going on with the pressure inside of the head. So headaches that are worse on awakening and that are positional, you should consider that this is probably due to increased intracranial pressure. She also reports some visual disturbances, which is also positional, so that also supports what we're thinking. The past medical history is positive for acne, for which she uses retinoids, but she doesn't use them anymore. She's 160 centimeters tall, she weighs 112 kilograms, she's a bit obese. The vital signs are normal. Visual acuity is 20/20, and this is important. Fundoscopy reveals bilateral blurring of the optic disc margins, and this just means optic disc swelling. Again, that supports what we're thinking, that this is due to increased intracranial pressure. Now we have to look for the cause of that increase in pressure. So they perform an MRI and MRI venography. They're both normal. And they do a lumbar puncture, which reveals elevated opening pressure. It just means there's increased intracranial pressure. And the CSF analysis is normal. So we have a middle-aged obese female who has a headache, some visual disturbances, and increased intracranial pressure. This is the classic case for idiopathic intracranial hypertension. So you have elevated intracranial pressure, but you have no identifiable cause. So this is idiopathic. Now, back in the days, they used to call it benign intracranial hypertension, but the headaches are disabling, and patients might even go blind because of it. So nothing benign about that. So now that we got the diagnosis, they're asking about the most appropriate initial step in management. So all the answer choices are actually potential options that you can potentially use when treating a patient with idiopathic intracranial hypertension. And answer choice A, acetazolamide. This is the correct answer. Acetazolamide is the most important initial step in management. The first thing you need to do is you identify any risk factor for idiopathic intracranial hypertension and then address them. So if the patient is obese, advise them for weight loss. If she's taking any medications that could precipitate her condition, for example retinoids, so she should stop any of the medication that could precipitate it. Acetazolamide is a carbonic anhydrase inhibitor, and it's a diuretic, but it has a great effect in reducing the pressure inside of your brain. And that is the initial step in management. Now looking at answer choice B, prednisone therapy. Glucocorticoids can potentially be used in the acute setting. This is usually reserved for patients with acute, severe, rapidly progressive course. So that's fulminant idiopathic intracranial hypertension with rapidly progressive visual loss that does not respond. You can just use prednisone. In this case, we don't need them because the visual acuity is actually 20/20. So that answer choice is wrong. C is transverse venous sinus stenting. This is relatively new. A lot of the studies show that patients with this condition have stenosis of the transverse venous sinus. And they believe that stenting that sinus would actually improve the patient's condition, which is true. In a lot of cases it does, but this is relatively new, and this is not the initial step in management. You could potentially consider that, but it's not the initial step in the emergency setting. D is ventricular peritoneal shunt. Again, this can also be used, but this is usually reserved for patients who do not respond to therapy, patient who still has progressive visual loss and headaches, and patients who we cannot manage with acetazolamide alone. We can go for options like surgery, and in this case, ventricular peritoneal shunt. So this is wrong. This is not the initial step in management. E is furosemide. This is a loop diuretic. Again, that also can potentially be used, but this is only if the patient doesn't respond to acetazolamide, and it's used alongside with acetazolamide, so we can't use it alone. So that answer choice is also wrong. F is serial lumbar punctures, which again can be used, but they're only used as a bridge to surgery. So if they do not respond to treatment, they have progressive visual loss, then you can perform serial lumbar punctures to reduce that intracranial pressure until the time for surgery, but it's not the initial step. G is optic nerve sheath fenestration. Again, that also can be used. This is also for patients who fail medical therapy and who have progressive visual loss despite acetazolamide therapy. We can potentially perform optic nerve sheath fenestration. The reason behind that is that the optic nerve sheath is actually continuous with the meningeal layers, so the pressure around the optic nerve is similar to the pressure inside of your head, and that's why this condition can affect vision and potentially cause visual loss. So the idea behind this is they just put a bunch of holes within the optic nerve sheath so that CSF can escape, and it doesn't exert as much pressure on the optic nerve. So the takeaway point is that idiopathic intracranial hypertension can present with headache and visual loss, but all the investigations are normal, except for fundoscopy, which can reveal papilledema. Now, another thing that I want to mention is that the patient that may also tell you that the patient has abducens nerve palsy, and this is a false localizing sign, meaning that when you have elevated intracranial pressure, then that can potentially compress the abducens nerve on the ridges within the skull, causing some transient dysfunction. They call that a false localizing sign, meaning that the lesion is nowhere near the abducens nerve. And in fact, in this case, there is no lesion at all. That's why they call it a false localizing sign. Another interesting point that I doubt you'll be asked about this, but this condition can also present without a headache, so it can be asymptomatic, and the only way to detect it is by routine examination, where you can find papilledema, and you work it out and you notice that the patient has no other cause for increased intracranial pressure, and you can diagnose it with this condition. But this is rare, and you're probably not going to be asked about it. So the initial step in the management of a patient with this condition is acetazolamide. That's the most important initial step, and you should know about this for step 1 and step 2. So this is it, idiopathic intracranial hypertension. You can leave a like, subscribe to the channel if you want, and thanks for watching.